expense, always not there. If there's any other reimbursement across the country, but I do a lot of ABI teaching across the country, and to my knowledge, Ontario is the only province that has it, and that's what we get paid. But in the U.S., you have to have that waveform as well that Dr. Dieter showed you to get reimbursed for that, because that number that waveform will match your ABI number.
Great. I know that there are some states have certain criteria. If you show evidence of disease, so the doctors that I know, they do ABI on everybody, and then they submit for reimbursement those who have poor ABI, and they get reimbursed for those patients. And that's, I don't know, a way of surviving your practice. Do on everybody and get reimbursed on certain people. We're going to move on to the next part of our meeting, and we're going to have a break sooner than expected according to the program. So the next part is systemic biomarkers, and Michael is going to walk us through the journey of CRP and other markers of inflammation. We have two more slides, two more presenters here, and then we'll take a break.
Does this work?
Thank you. As I said, I come from a little bit different perspective as a lipidologist, and so I want to try to give you insights from that school of thought. And also, just to keep in mind that when you develop guidelines, you probably need to think about Mitchell, South Dakota, as well as Los Angeles or Lenox Hill in New York City too. So it's always something to think about when you're trying to develop new approaches to screening for cardiovascular disease. So CRP, I know this is a story that's well known to everybody here, and it's held up very well. And most recently, in the Lancet, had a very large emerging risk factor collaborator group, and this is about 200,000 patients. CRP was shown to be a strong predictor of cardiovascular events, heart disease, ischemic stroke, and all vascular deaths. If you compare it to other traditional risk factors, CRP had one of the highest risk ratios of some of the, what we use commonly, systolic blood pressure, total cholesterol, and even non-HDL cholesterol. So we've already talked a little bit about the Reynolds risk score, but I thought I'd bring up again that it doesn't incorporate CRP and family history. Again, my bias is that CRP represents more than anything visceral adiposity inflammation. If you biopsy the visceral fat, you find a tremendous amount of macrophages. And I think it's naive to think it really comes from the artery wall. It's by far the visceral fat that is picking up the signal of high CRP, and that's probably why, I'll explain in a minute, the Jupiter study did not show a benefit in the high CRP patients that did not have other risk factors present. So this is important. I think the Reynolds risk score will probably better reflect the U.S. population and other growing populations where metabolic syndrome is becoming more and more prevalent as a better risk score than the Framingham risk score. So there's Jupiter, very positive study, early benefit, stopped early because of overwhelming reduction in cardiovascular events and mortality. The mortality difference was significant. I'm sorry. Let me see.
Should we resume?
So there is overwhelming benefit that was stopped early. And I think what's interesting is that the benefit did not matter, at least relative risk benefit did not matter regardless of the baseline LDL. So 100, 90, 80, 70, 60 LDL all had benefit with rosuvastatin therapy in this population. And the best result was those who had a CRP less than 1 and an LDL less than 70. And one of the criticisms of this analysis is that the patients that had a lower CRP to begin with, or lower risk, are more likely to get down to less than 1. So it may have just reflected a lower risk population in general. The patients who did not get below 70 LDL, independently of CRP, did not have a benefit with rosuvastatin. So those who believe in the target, like myself, can argue that you still need to get to a target to maximize risk reduction. The same is not true for CRP. Those who got lower CRP did better, but you need to get below 70 LDL in the study to have a benefit. So the incorporation of the Jupiter study has already been put into some guidelines. We'll have to wait and see what ATP4 has to say, but again, if we want to try to be consistent with some of the other guidelines that have come out recently, like the Canadian guidelines, they added in the Reynolds risk score at over 20% as a rationale for aggressive treatment. They did a couple of things interesting. One is a target, less than 2 millimoles, which is about 80, but also just a 50% risk LDL reduction. And that's getting to those who believe in statin only as a therapy, not reaching a target. Just give a statin and then forget about it.
Michael, in the absence of a low CRP group on admission, how can you reach any conclusions about the study?
What's that?
The Jupiter study, everybody had a high CRP, wasn't that the criteria?
Yes, everyone had high CRP, but
So how do we know that?
That the same thing is not true in people who had low CRP.
well, the thing is, it would take. I mean, that's
Another 2 years.
the CRP did its job. I mean, it worked. The risk was double than expected in the high CRP group. So it's getting the same concept that you're talking about. Only picking people with cardiac calcium to treat. You know, CRP is doing the same thing. It's picking at why would you do a study in zero calcium, and even how do you know people that would benefit as much in the study?
We will get there later with polypill discussions that regardless of the level of CRP, regardless of the level of coronary calcium, you put them on polypill, you're going to get great results. Then we're going to answer that question.
Okay. But I think that the criticism of why is to pick people without CRP elevated is you wouldn't have any events in that group.
Very low.
Very low. So that's the problem with that. So I think the Canadian guidelines did pick the CRP as one of the criteria for more aggressive intervention. And as a target too, as a secondary target, which are all optional. So the FDA did approve new indication for Crestor. I want to sort of point out the very point. This is the important point. You had to have another risk factor present, such as hypertension, low HDL, or smoking, or family history, to qualify for therapy. And this was the Jupiter study was also validated by the Arab population, which looked at the same kind of Jupiter eligible patients, which is CRP greater than less than 130 and over 2, and they had a high event rate, even higher than those at high LDL, low CRP. And so did also high cancer mortality too. So CRP was picking up a high risk group for overall mortality, cardiovascular, and cancer mortality, which is something that needs to be validated in other studies. So based on Jupiter, this is Paul Ridker's statement that we could use it as a way to identify a simple screening test to certainly prevent a number of cardiovascular events. So with that in mind, let me move on to LPPLA2, which I'm I like it as a test that's more vascular specific, but I think the downside for this group to get involved with LPPLA2, with all due respect to all those enthusiasts for it, because I do like it as a test, it does work well, as well as CRP in multiple trials. And because it is more vascular specific, people have thought it could be better than CRP or replace CRP. But the difference is that it doesn't have Jupiter as a study yet. It doesn't have an evidence-based trial to support widespread screening and utilization. And there's also a drug in development to target LPPLA2 that may expand its utilization. And we'll have more data on this trial in the next year or two. So I think it may be a little premature to advocate for it strongly. I mean, maybe something we can talk about in your guidelines, but my opinion would be to not emphasize it too strongly in your recommendations, because the stability trial will be finished in 2 to 3 years, and it may change how you think about LP-PLA2 as a target, as a risk predictor, and as a therapeutic approach for cardiovascular disease prevention.
This is equivalent to Jupiter.
Stability is
5 years ago.
it's high-risk people, all secondary prevention. I think getting to rapidly, which is CETP,
That by
LP-PLA2.
definition puts them outside of shape,
Right.
because shape is focusing on ice.
I know, but it'll validate the target, validate the activity, the treatment of this target, yes. I think that's the one thing, it's a secondary prevention trial. So LP-Lili, this is something I think that deserves more attention, and I won't go through all the details of it without time, but there's, again, very good studies showing benefit, risk prediction. Most recently was this trial from JAMA, is a causal factor of MI in the general population, very high hazard ratios, about 2, and those that had high levels of LP-Lili. And I want to, again, say there's been very recently from the European Atherosclerosis Society in Germany, the meeting in June, July, recommended LP-Lili screening for those with family histories or recurrent heart disease events as a strategic approach. And so if you want to try to be consistent with another large body that's involved in screening recommendations, this would be something that was already endorsed by the European Atherosclerosis Society.
How would you see that improving what we have?
Yeah, so do you want the checklist thing?
It would be one of the-
What we talked about? Yeah, one of the...
Well, we have to measure it in order to...
Right, to measure it. So what I did here, and this is going to maybe raise a lot of discussion, we can talk about this later, but so how would you incorporate these tests into a shape light program? So you want to look at the, let's go on the other side. So you already have evidence-based approaches for treating diabetes. So ADA recommends anybody over age 40 with diabetes, regardless of the baseline LDL, should be on a statin. So what you could propose is that if you do have diabetes, aspirin and a generic statin with the coronary calcium or the IMT to intensify therapy, to put them in the higher risk category. Diabetes plus CHD, basically, for more intensive therapy. Non-HDL is probably the likely target out of ATP4 instead of LDL, because that's becoming more and more recognized as the better target, especially today. So that has evidence, and I think little disagreement, at least at this point, using the imaging modalities to put somebody into the, quote, very high risk range. Then we have the intermediate risk, so at least one risk factor or metabolic syndrome plus CRP less than 2. That's basically the Jupiter population. And again, you could say aspirin and generic statin, and then imaging to put them into the more intensive therapeutic approach. And then we have the all others, basically, that would have at least... Then we have the low-risk patients that would have one risk factor, metabolic syndrome, or one plus risk factor with CRP less than 2, and those you would consider CAC or IMT if positive family history or high LP-Lili. This is where there's less evidence, but I think that with what we've shown today, that we have a strong rationale for treating those that do have evidence of preclinical disease, and that would move them into this category. So it's not quite this. You have 2 levels of I didn't define what consider positive here. I think that's up to a lot of the other experts in the room to define what level of preclinical disease you want to mark as being as intensive.
But you're still basing your risk assessment, the foundational determinant based on risk factors.
Right.
Rather than the disease.
Right, so it's based on risk factors rather than, it's not, instead of like an all-screen strategy, it's based on a risk factor targeted strategy. We'll get this later, but here's the metabolic syndrome parameters, just to kind of keep those in mind. Here's the waist, I made the Asian waist circumference instead of the Caucasian, which might be a little bit more sensitive. Your family, and then this is a lipidology perspective that once you do get non-HDL goal, you may want to consider ApoB or LDL-P as optional targets. Once you're at non-HDL, that's what the ADA ACC consensus statement said, suggested that approach. So this is the kind of initial assessment. These are evidence-based strategies, and this would be the one that would be kind of this would be basically the shape approach to those lower risk patients. Okay, thank you. Yes, that's it, thank you.
Great. So this part, we will get back to the consensus guideline. It's most likely going to be fresh tomorrow morning rather than at the end of the day today. But today, these kind of presentations touch on each subject, pros and cons, and you just heard the pros on CRP and inflammatory biomarkers. We're going to the cons part for some critical view that Sanjay is now famous for, thanks to all these online blogs.
Well, thank you. I've been asked to offer an alternative interpretation of the evidence that Dr. Davidson just touched upon. And at the very outset, I'll have to say that when two reasonable people look at the same evidence and interpret it differently, it speaks to the weakness of the data and not to some irrational commitment to one's point of view. So I hope you don't mind if I interpret the evidence differently. And I'm going to provide my perspective, not as a clinician or as a trialist, but as an evidence appraisal perspective of it. So it's going to be a little bit more rigorous. So the issues for discussion are, first I'll try to characterize the relationship with cardiovascular disease. Is it a marker mediator or an epiphenomenon? And then I would like to get into the predictive performance vis-a-vis association, discrimination, calibration, and reclassification, as any good model should be able to elicit. And then briefly talk about its clinical utility, particularly in therapeutic triage, treatment target, and does it have a role in guidelines. Now, this is a slide that looks at three possible relationships. Is it a marker of disease, which means that there is induction of CRP expression in the liver by inflammatory cytokines that are released from the atherosclerotic arteries? Is it a mediator of disease? There is some metabolic disturbance that leads to CRP from liver, which then induces the plaque. Or it's true and true, but unrelated. In other words, it's an epiphenomenon. Well, let's look at the hierarchy of evidence that sort of tries to answer this question. When we look at the gold standard, the randomized controlled trial, currently we don't have any. Simply because we don't have any therapeutic agent that can directly target CRP without modifying the other metabolic factors that are associated with cardiovascular disease. There are in development, but we simply don't have any trials looking at that. The next best is the Mendelian randomization study, which basically demonstrate whether the risk factors lie in the causal pathway. And I'll share with you the data that it's really, it basically suggests that the CRP is not causal. And then we have the case control cohort studies, which are generally positive, but in of themselves are insufficient, in my opinion. And then we have the preclinical evidence, where the data are somewhat positive, but inconsistent. So this is the example of the Mendelian randomization studies. So if there is genetic variation in CRP gene that is associated with plasma CRP levels, and plasma CRP levels in turn associated with cardiovascular disease risk, ergo, the genetic variation in CRP should be associated with cardiovascular disease risk. And this is the data from, there are 4 sets of studies from Copenhagen. And basically, do I have a mark here? Oh, yeah. So when you see here that there's a CRP genotype combination number 9 predicts a 64% increase in CRP level, which would have then predicted a risk ratio of about 1.3. But what you actually observe is a risk ratio of about 0.84. It's the opposite of what you had predicted. And shown below here is the positive, the internal control that this type of APOE genotype associates with 14% increase in cholesterol risk, which is then associated with the increase in cardiovascular risk as you would have predicted. So from these kind of studies, we know that CRP is a marker, not a mediator. It's sort of an innocent bystander. Let's talk about strength of association. Now, statistical associations may be necessary, but they're not sufficient to establish a relationship. And then the discrimination, calibration, and risk classification. I'll go over this. Paul Rickler always shows this slide, that CRP adds prognostic information beyond traditional risk factors in all major cohorts evaluated. There have been about 14 such of these cohorts. Yes, consistently it demonstrates an association, but that's not enough. This is the data that Mike just showed about. This is the emerging risk factor collaborators, which is the largest meta-analysis of its kind, 54 prospective studies, 28,000 events, and they were adjusted for conventional risk factors and inflammatory biomarkers. And again, you see a risk, an association, which is similar to that with blood pressure, cholesterol, and non-HDL cholesterol. In essence, it's a modest association. And LPLA2, this is a similar type of meta-analysis just recently published in Lancet. Risk ratio here is around 1.08 to 1.16 for every standard deviation elevation. Not a very strong correlate of CHD disease. Now, what do we mean by that? Shown here are 3 possibilities when we talk about the predictive performance. Here, you cannot discriminate non-disease cases from disease cases. This is what we call a chance line or a C-index of 0.5. And as the predictive performance improves, you get better discrimination. But shown here is the relationship between the odds ratio between the first quartile and the height of the 5th quintile, and what is the detection rate at a 5% false positive rate, in other words, positive predictive value. So you see an odds ratio associates with a detection rate of 11%. So if you have an odds ratio of 1.1, is it very surprising that you get such a low positive predictive value? Similarly, if the calcium score has an odds ratio between 5 to 10, you should see no more than 14 to 20% positive predictive value. The fact that you only get to 4% in MESA is quite surprising, because I would have expected it to be higher.
It was very short-term follow-up.
Yes, for short term, and so, yes, but that's what the data is. Now, look at the positive predictive value in Jupiter. We have a total of 241 events occurring in 17,802 patients. Positive predictive value of an elevated CRP is about 1.35%. And when you compare this with MESA, for all-comer cardiovascular events, it's about 3.6%. For MACE events, the harder endpoints, it's about 2.1%. And for whatever reason, these positive predictive values may perhaps be an underestimate. But there's nowhere near the 14 to 20% that we would have predicted based on the odds ratio relationship. Does CRP increase the C statistic? And shown here are about 7 studies, and you can add MESA to it. Essentially, not much, with the exception of 1 study, which is the monitor study. CRP does not improve discrimination, but neither does carotid INT if you subject it to the same rigorous analysis as in the cardiovascular health study. You have a strength of association varying from 1.2 to 1.3 for stroke or cardiovascular death. And so, accordingly, you don't expect the C statistic to move, which is exactly what was shown in the cardiovascular health study.
But they removed plaque, they didn't include.
They did not include that. That's why I'm saying only CINT. CRP, right.
Plaque. And then you saw this morning,
Right.
80% plaque.
The point I'm trying to make here is that the strength of association has to be very high, odds ratios of greater than 10 before it moves the compass. That's the point I'm trying to make here. So it's not surprising, even if you have an odds ratio of 1.5, 1.8, don't expect a major improvement in discrimination. What about calibration? This is the data from Women's Health Study. Yes, a CRP does improve calibration. What about reclassification? This is the data from the Reynolds score 10-year risk, which is using the best fitting model in the Women's Health Study. According to the investigators' analysis, they concluded that large proportions are reclassified, nearly 40 to 50%. Well, let's take a closer look at it and see whether these conclusions are borne out. When you look at the data here, shown here is the ATP estimated, and this is the 10-year Reynolds predictive risk. Essentially, 92% remain unchanged. When you look at the numbers that are correctly reclassified to a higher class, less than 1%. Incorrectly reclassified to a lower class, about 1%. Correctly reclassified to lower class, about 0.3%. So when we look at the overall performance, the conclusion is that the deck is reshuffled, but with no real net gain in Prouder classification, which is predicted by the absence of change in the area under the curve. You would have predicted that. Now, on the other hand, coronary artery calcification has been shown to have a better reclassification. As a clinician, it's hard for me to be convinced that I will de-escalate my therapy if somebody moves to a lower class. I'm more likely to escalate my therapy rather than de-escalate my therapy.
But as a clinician who doesn't care about data, but if you're a clinician who cares for data, why not lower it?
There's no data to inform that. I mean, I like to hear anybody here. Has anybody looked at a reclassification to a lower category and you de-escalate therapy and your outcomes are not changed?
No, I agree. This
not.
shape has always been used.
But my instinct as a clinician are to escalate therapy, and I would submit that perhaps I reflect that the majority's mood here, right? I mean, I don't think we're ready to de-escalate therapy just because we shift to a lower class. Well, let's talk about Jupiter, because Jupiter was brought up here. In the Jupiter study, 53% of patients were excluded because the LDL was greater than 130. Not surprisingly, because the LDL associates with other risk factors as well as elevated CRP. But more importantly, about 37% of patients were excluded because of low CRP. So more patients were excluded due to CRP being less than 2 than were actually enrolled in the trial. And as was already brought up, without a low CRP arm, the CRP hypothesis truly cannot be validated. Now I hear that these patients were unlikely to benefit. Well, that is a post hoc analysis derived from the AFCAPS TEXCAP study. If it's a post hoc analysis, it can only be hypothesis generating and exploratory. We cannot say this is hypothesis confirming. So I think it was a missed opportunity in the Jupiter study that patients with low CRP were not included in that arm. Now I understand, because for practical reasons and all that I understand all of that. But I'm just saying that it's a missed opportunity to confirm the inflammatory hypothesis, especially given that Paul Ridker has spent his entire professional life trying to validate the inflammatory hypothesis.
But with this data that you showed, including the master meta-analysis that you showed, that CRP was not hugely predictive, but low CRP, don't you think is associated with low outcomes?
That's a post hoc analysis derived from an AFCAPS TEXCAP study.
How about based on the meta-analysis, that major meta-analysis?
No, what we're talking here about is CRP less than median and CRP less and LDL less than median. That was the cell that had not much of a treatment benefit in the AFCAP TEXCAP. All I'm saying is that if you're going to say that this is a post hoc analysis, You can only use it for generating hypotheses. You have already concluded that patients with low LDL and low CRP are not going to derive any benefit, which I think kind of is self-fulfilling prophecy. Yes?
Do you remember in Jupiter how many times they measured CRP to get into the trials?
I think it was 2 or 3 times, I
And
believe.
the mean had to be above 2, or because of the variability in CRP?
Right, I think the mean had to be, I don't know the details, maybe Mike will know, but the point is, here's this very interesting study that I'm presenting from Jupiter, which only came out during the FDA deliberations, and in the interest of full disclosure, I was on the advisory panel. And what we did here is we broke the data, the primary endpoint data, according to different cutoffs of CRP. This 4.2 was median, 4 and 3 or less than 3 based on the CDC criteria. There are 2 interesting observations. Red bar is the placebo arm, and the blue is the treatment arm. First of all, let's see, what's the relationship between CRP and the placebo arm? A flat dose response. But when you look at the treatment intervention, you have an inverse relationship, such that individuals that have lower than your cutoff value for CR, the treatment benefit is almost twice as large as that you see in individuals that have CRP greater than the cutoff. Now, of course, this is a very restricted CRP distribution because by design, patients had to have an elevated CRP, greater than 2. So we can't say what would be the relationship across the entire range of CRP, but that's the data that we have. Now, it was brought up that, if I can go back here, it was brought up that, patients in the Jupiter study, we were asked to vote by the FDA. We were asked, the advisory panel was asked to vote on the question based on Jupiter eligibility criteria. Did they meet their endpoint? I want you to focus on this green bar data here. Less than 2 ATP3 risk factor is the Jupiter eligibility criteria. See what the treatment effect there is. A modest 9% risk reduction, which was not statistically significant. But when you add one additional ATP risk factor, which is the majority of the patient population, see you get a whopping 50% risk reduction. An interaction term between the two is significant. Even though the panelists were asked to vote on the question, would you approve rosuvastatin based on Jupiter eligibility criteria, we were extremely reluctant because we felt that expanding the patient population to rosuvastatin for primary prevention was not the right thing to do. So we demanded that we have one additional risk factor borne out by this analysis, even though it was post hoc. And to the FDA's credit, they listened to the deliberations and not to the vote. It was brought up that there was a significant mortality reduction in the Jupiter study. Well, guess what? The FDA did not allow a mortality claim. Why did the FDA not allow a mortality claim? For the following reasons. The mortality was not a pre-specified endpoint. It was a post hoc secondary exploratory endpoint, number one. Number two, it was not adjudicated. Number three, when you take out the vital status data, for which you really cannot confirm those deaths, because they're based on public health record data, which may be manipulated easily, the differences were not statistically significant. Number four, the p-value was 0.02 unadjusted. When you adjust it for multiple comparisons, you lose the significance. And more importantly, number five, when you look at the mortality data at 4 years, there was a 1% absolute risk reduction in mortality. But when you extend the study follow-up by another 6 months, at 4.4 years follow-up, that had diminished by about 50%, which underscores the point that if you have prematurely truncated trials, your treatment benefits can be likely be implausibly large, that regress to the mean, or as somebody says, regress to the truth, if you were to follow up for a longer period of time. So to this day, I have not heard a compelling explanation as to why Jupiter study was prematurely stopped. Because if it was stopped on the basis of mortality, the mortality was not driven by cardiovascular mortality. It was driven by cancer mortality, which is likely to be a spurious finding, which again detracts from the wisdom of the decision to prematurely terminate the trial. So for these reasons, the FDA and the panel did not allow a mortality claim in Jupiter. Now, this has been already brought up, that if your LDL is less than 70 and your CRP is less than 1, you get the greatest treatment benefit. Well, these are arbitrary cutoffs. They were never pre-specified. Patients were never randomized to treatment targets. And the value of less than 2 and less than 1 are again based on arbitrary levels, based on post hoc analyses of reversal and proving. And that's the reason why none of the guidelines have allowed CRP cutoffs or LDL cutoffs less than 70 as principal treatment targets, including the Canadian guidelines, where they asked CRP to be less than 2 as a secondary target, not a principal target. So this is the AHA-CDC statement about CRP. It's an optional use, which means not mandatory. It's a class 2 level B recommendation. Same thing with the Canadian guidelines. It's a class 2A level B optional recommendation. And the chair of Canadian guidelines, Jacques Jeunesse, some of whom may know this individual, he claimed that these recommendations were purely, strongly evidence-based. And I was struck by his statement. I often use CRP not to treat patients, for example, those at moderate risk according to Framingham, in whom therapy can be deferred if CRP is low. Now you be the judge if these are strongly evidence-based. This is the point that I was again making. This has already been shown. It's a class 2 level A recommendation, but look at the CRP less than 2. It's a secondary treatment target. Now, are these data borne out in the Jupiter study? The Canadian guidelines say that if you are at intermediate risk, if your CRP is greater than 2, maybe you should be candidates for pharmacotherapy because Jupiter says that you're going to get greater treatment benefit. Well, let's look at the data. This is the classification of patients according to the FRS score, and then further reclassified whether their CRP is greater than 4.2 or less than 4.2. What do you see here? In every category, there is treatment benefit. That's not the issue here. But look at here. You get a 66% risk reduction if your CRP is less than 4.2, compared to a 35% risk reduction if your CRP is greater than 4.2. Are the Canadian guideline recommendations borne out by the Jupiter analysis? What are the limitations of this analysis? Again, we have a very truncated CRP distribution. We really don't have CRP less than 2, so that's one of the major limitations of this analysis, but this is the best we have so far that sort of contradicts the Canadian guideline classification. Now, some of you are aware of this, a very controversial paper by Helfand and his evidence-based medicine group. AHRQ actually commissioned this, looking at 9 non-traditional risk factors. And basically what they said was that none of them, including coronary calcium, Lp(a), homocysteine, and CRP, had the evidentiary gravitas to qualify as a screening tool. There is insufficient evidence to recommend the use of non-traditional risk factors for screening asymptomatic men and women with no history of CHD diabetes or any CHD risk equivalent. And John Ayana and his colleagues also sort of looked at all of these risk prediction tools. This is what they concluded. Majority of examined studies had flaws in their design, analyses, and reporting that cast some doubt on the reliability of the claims for improved prediction. Currently, incremental predictive effects are difficult to discern from the spurious effects that biased analyses or reporting can create, thereby providing support for this kind of interesting acronym HSCRP, standing for highly spurious claims of risk prediction. So just to summarize, There is a modest association, but we have to focus on clinical relevance rather than the statistical significance. There is poor incremental discriminant value. It is not implicated in disease. We currently do not have any therapies that directly target CRP. There is questionable evidence for therapeutic triage or treatment goal, and there is questionable evidence whether it can be used as a tool to motivate compliance. So the verdict is in. The evidence base supporting the inclusion of CRP in CVD risk assessment is modest, incomplete, and overstated. On the basis of the available evidence, calls for the widespread adoption of CRP measurement as a screening test must be regarded as premature and unwarranted. And with a favorite quote of mine from Mark Twain, there is something fascinating about science. One gets wholesale returns of conjecture out of such a trifling investment of fact. Thank you very much.
Quick question.
Yeah, go ahead.
Did you or the FDA recalculate the NNT in Jupiter? 'Cause
Oh, yes,
When I
yes.
did it, it was different than what's actually in the publication.
Okay, I think it's very important to keep in mind that the tendency to standardize NNT estimates should be avoided. It's extremely misleading. The NNTs only apply for the time the data period were collected. And so the NNTs were collected for about 2 years, a median of 2 years in Jupiter, but they were projected to 5-year estimates. This extrapolation to 5 years or interpolation to 1 year is statistically an invalid exercise for the following reason. Because the treatment estimates in Jupiter were not very reliable, because the treatment trial was truncated prematurely. You can catch it at a random high, or you can catch it at a random low. So the appropriate NNT estimates in Jupiter are about 81 for the primary endpoint, and for every other endpoint, it's over 100. And if you multiply, you do your crude cost effectiveness analysis for the primary endpoint, it comes to around about $300,000 per event avoided. But if you factor in the generic statin cost, maybe that might yield societal benefit. But at the cost of rosuvastatin, which is about $3.72 per day, it is unlikely to yield societal benefit.
Thank you. We're going to have one more presentation, but before that, I'd like to Michael to just counter and see if you can, go back to FDA. We have one more presentation and we'll take a break.
Just a rebuttal, and it's not, I'm not going to actually argue the science because I think it's, we could argue the science a lot. It's more of a political argument for this group, and that is that if you bypass CRP in the Jupiter study, it is with all the limitations of that study, and I'm, as you see, my point of view and another point of view, that it's an evidence-based study that used CRP as a screening tool to pick up higher risk patients for intervention. We don't have that study yet with coronary calcium IMT to put people in the study based on a low LDL but a high coronary calcium and a high CRP, high CIMT, and then give them a statin or no statin and follow them for a period of time. So I was telling Paulo before he left, I said if you try to get AstraZeneca to do that kind of study, get people with coronary calcium but low LDL, put them on statin or no statin, and looked at follow-up. That would have been the Jupiter study for coronary calcium. You don't have that study for CAC or IMT. So for an organization to recommend CAC and IMT screening and just avoid the issue of CRP, I think would be not a politically wise move if you want to get these guidelines adopted. Because the key thing is you can have guidelines, but if they're not adopted or they're not supported, then they're not going to have significant value.
So, Michael, I think you're out of the room. I showed the St. Francis Heart study that was a randomized trial of Lipitor 20 versus placebo with a high calcium score as the baseline entry criteria. It's exactly the Jupiter trial done with calcium scoring instead of CRP. And it showed a 44% benefit, which is exactly the same number that we got from Jupiter. So we have the Jupiter study already done with calcium score. We do not have it
But
with.
that wasn't the primary point calcium progression though? Was
No,
not,
it was
not
outcomes. It was an outcome study. It's called the St. Francis Randomized Outcome Study. It was an outcome study published in JACC 2005.
Uh-huh.
Yeah, well, my.
So the p-value was borderline, it was .046, because they only had 1,005 patients randomized. It wasn't a 17,800 person randomized trial. But we do have that exact data. I agree with you, it'd be nice to have a much larger trial, but today, trying to sell positive calcium score randomized to placebo, I agree, is more than an uphill battle. It might be an unethical battle.
So that's why I'm proposing we join, you know, you don't fight it, you use the Jupiter study as a way to intensify therapy for those that do have coronary calcium.
It would be great to do that with carotid IMT as well as coronary calcium.
Right, exactly.
So you have both.
I'd like to ask you, Sanjay, about de-escalating therapy. I would submit that using evidence-based medicine, there is not a single study that shows that you can reduce the event rate of, for instance, a zero calcium score patient, lower than 0.1% per year. And I would submit, because you are doing something active, you're giving a drug with costs and side effects, that the burden of proof is on those who would treat patients with zero calcium scores, rather than those who would withhold therapy.
I don't see it that way. The burden of proof is on those who claim that a calcium score of 0, regardless of an elevated FRS, is proof enough to de-escalate therapy. I have a different perspective on this. I mean, you are making that claim that you have a calcium score of 0 despite an FRS of, let's say, 12 or 13. I feel comfortable not treating that patient's LDL, which he would have otherwise qualified for.
Yeah, I think we don't have the long-term data.
Yeah, this is not in alignment with my instincts as a clinician. I feel very uncomfortable telling that patient, you know, we have a calcium score of 0, it's a very strong predictor, it doesn't matter your LDL is 150 or 160, you know, just go ahead and do whatever you want to do, or lifestyle intervention, and we'll not treat it. It just doesn't sit well with me. And do I have any evidence to rule that out? No, I don't. But you are making that claim, so the onus is on you to do it.
Actually, I don't think so. I think it's the opposite. I'm not advocating withholding therapy in a group that has a reasonable risk. This group is the absolute lowest risk possible. And if you're going to administer a drug, don't you think you should have some data that you're going to improve their outcome?
Harvey, you're arguing two different things. Sanjay's saying de-escalation of therapy. You're talking about initiation of therapy.
Yeah.
They're absolutely different. SHAPE is about initiation of therapy based on perception of risk. And I think Sanjay, hopefully, and Michael as well, would say if you had a high calcium score or a CIMT or a CRP, that would be an indication for a statin. If you had a low CRP, or a low CIMT, or a low calcium score, would you take somebody who's already taken a statin and say, stop it? And that's where we don't want to go, because that's de-escalation.
That's
how we
I
don't
see
have
it.
evidence.
You're right, and I'm not talking about that,
Right,
because
because
the
that's-
argument can be made they have a zero calcium score because they're on the statin, perhaps. But statin-naive patients, irrespective of the framing risk score, what justification can there be for putting them on drug therapy if they have a zero calcium score?
The only justification is you have not had a long enough follow-up on those individuals. They will become coronary calcium positive in 10 years because you did not treat them. They will.
I think Harvey is making a very good point. If you look at the indication for rosuvastatin in UK or the EU, they completely discount the Jupiter data. They say that we are not going to allow rosuvastatin for primary prevention unless and until the FRS score is greater than 20, or the score that they use is greater than 5. Why? Because they found that in a subgroup analysis of 1,600 patients and thereabouts in the Jupiter study that had a FRS score greater than 20, which was an exclusionary criteria for Jupiter, nonetheless, about 1,600 patients got into the trial for whatever reason. That's where you had maximum benefit. So the British and the European guys are saying that we will only allow rosuvastatin for primary prevention if
your CHS, the risk score is greater than 20%.
Yeah, well, we know that they're
Because the CRP does not factor into
yeah,
their.
but we have a fundamental problem with their guideline. That is, they're not measuring disease, they're measuring risk factors.
Right.
And if you had a measure of disease, I bet you within the Jupiter, you could have found a subgroup of huge improvement in outcome, because you basically treat people with significant amount of disease. We're not measuring an indicator of disease, we're measuring a risk factor. CRP or framing, if you both of those, in our views, I mean, you elegantly presented CRP is a marker. It has an association. It's not, I mean, at best it's a risk factor. It's not equivalent to disease. You lose weight, you lose CRP. Well, that doesn't mean your plaques go away.
I must respectfully submit that whatever I said about CRP, I think I can make a compelling argument by extrapolating it to CAC as well.
Well, I think,
But I feel that there is relative value to CAC. There's an incremental value to CAC compared to CRP. But all the things that I said about CRP can be applied.
if you talk completely like a statistician who don't understand plaque versus CRP, well, plaque is plaque, but if you understand that plaque is coronary is the substrate for disease, or CRP circulating in fat cells, it's not a substrate for CRP. You do draw
There's a strong biological argument for
right.
using CAC over and above CRP. Yes, there is a strong biological.
That's what.
But Sanjay, you have to be a little bit, I would say, enthusiastic about the fact that almost every study ever of calcium scoring shows an improvement in the area under the curve.
By a very small amount.
Well, we'll see you're right, but I mean, we'll see the recall study as well, but every study at least moves it in the right direction,
Yes.
where we have not seen that uniform data with CRP.
Well, that's why as part of, I don't know how many of you are, I think Matt is involved and Steve is involved in the Greenland study. There was a very vigorous debate as to what we should choose as our screening factor tool there. And so we thought that, you know, we could use CRP, we can use CAC, or just treat everybody. And so by gradual process of elimination, we first eliminated CRP because compared to CAC, it did not perform as well. But that didn't mean that CAC was good enough.
Right. Well, there are two things here, and I actually, Raymond is going to show most of the CRP versus CAC prediction. But with CAC, the direction towards detecting disease, we have a way to improve on detection. You've heard the plaque. We see carotid INT has gone a long way comparing to that INT to that plaque volume, plaque characterization, and all that. That's ahead of you. With CAC, you know, E is scored. I don't know if you saw that. The additional information that comes to coronary calcium, you improve your ability to predict. But with CRP, you don't have anything. You just
No, please don't get me wrong. Please don't get me wrong. I'm saying that there is a strong biological argument for using CAC over any other tool that we had. But we should go into this with our eyes wide open, not wide shut.
No,
there's no way they'll ever have a marker with an ROC curve, increment of 10 or a hazard ratio of 10. This is a chronic disease that evolves over decades. It's quiescent, it flares a little bit. There's never ever going to be a marker with a hazard ratio of 5. So we are going to work with these little bits. And the other argument is don't work with them, just give everybody the fill.
No, that's the point. You're making exactly the point I'm making, is that be careful. Just because we have these risk ratios of 5 or 10, you have to understand what does it translate into in terms of clinically meaningful outcomes. Let's not get carried away.
But we have
I think we all have one reference to follow, and that's increased ROC, area under the curve. If we have a giant step up, we all cheat. We don't have a giant step up. We do have it in a small population with very high coronary calcium. We know that, but that only accounts for 3, 4, 5% of the population. So we need to work on that. The presentation that we saw from HRP study, 6,000 patients with so much plaque. If that comes out with something fantastic with no radiation, widely available, I mean that would be a breakthrough in our test. Erling?
I have a question to you.
You show data that CRP is strongly correlated, associated to coronary artery disease as cholesterol, blood pressure, and non-HDL cholesterol. Is it just because of history that we now cannot accept CRP, but we accept cholesterol? Let's say we identified CRP before cholesterol. Then today we had the discussion whether cholesterol should be included as a
The argument is somewhat attenuated by the fact that we have treatment that can target these risk factors. If we did not have therapies that could target this, we will be talking about cholesterol the same way.
Yeah, I'm sure.
Just like we have for HDL. HDL is a stronger predictor than LDL, and yet we don't have any direct treatment intervention for raising HDL.
But we will find many biomarkers in the future, genetic biomarker, proteomic biomarker, that will not be a target for therapy, but they are associated with risk. They improve risk assessment. It will help us identify people at high risk that need treatment. And of course,
you're making the point, it will help intensify. I'm perfectly comfortable with that. It will help escalate therapy.
And that's
I'm not comfortable with it will help de-escalate, because the majority of patients that we are going to identify would be theoretical candidates for de-escalation. And that's where I am very uncomfortable.
One point, and I think Matt might comment on this, is that I understand your point that an odds ratio doesn't always translate into meaningful.
It's a tail distribution. It's meaningless.
But having said that, I think we should be clear from the comments that are made that the studies in coronary calcium consistently show that the group that has a coronary calcium score greater than 100 is about 10 times the risk of the entire group below 100. That's very powerful compared to a CRP, which in meta-analysis is about 1.4, top quartile, the bottom quartile.
I agree. It's very powerful.
Right.
But now let's eliminate the relative performance and see what does it translate into. What does it translate into? A risk ratio of 10 translates into a detection rate of somewhere between 14 to 17%. Under ideal circumstances, assuming there are no other confounding relationships.
The way it clinically translates is that a score of 100 translates to a CHD equivalent in somebody who might not have been considered a CHD equivalent. So
attributable risk, absolute risk, all of these things kind of sort of, they shrink.
Sure.
So
I'm just saying the absolute risk is about 2% per year of a score of 100 without risk factors.
You don't have to convince me.
No.
Between CRP and CAC, CIMT, if I were to pick one, even though it did not meet my standards, CAC is the one that I would pick.
right. Well, I think the lay conclusion is in the land of blinds, a single eye, is the key. So CAC as it is today.
But that's not very reassuring.
That's not, but that is the reality. That's a reality. We want to improve it, and that's what we're working on. And I think with the knowledge that we got today, 3D plaque, and being able to correlate those with the outcomes that we have, in a year we might have a huge step up into it. But we have to be on a track that leads to improvement. With CRP, we're not on a track that leads to improvement. It's just an association. Now, if LPPLA2 comes out and you treat LPPLA2, we might, which data does not at least suggest that way, but it's not to bash CRP, it's just that how can we use that to improve our ability to increase treatment? And I think this next presentation, which is last before break, is showing us CRP versus CAC in one study. So let's go ahead.